Okie doke.
Okay. Thank you guys for joining us. We are Family Voices. This is our caregiver conversations, and Christy is presenting tonight on early periodic screening, diagnostic and treatment, EPSDT, which is a crazy long acronym, but it's really important stuff for those under 21 that are on Medicaid. So we're
It is
excited.
super important. So we'll get to that. Megan, did you have something else?
Yes, on the next slide, I think. One more.
Well, it didn't go. So hold on.
Yay, technology.
There.
There we go. Yes. These are caregiver conversations the first Thursday of every month from 7 to 8:30. We do these on a whole wide variety of topics that you guys tell us that you want. I have a quick sign-in thing if you don't mind filling it out. It helps us keep track of who we're reaching with these. So if you would put your info in there, I'll put it in the chat here in just a minute. That helps us. And it also has a link on it for you to tell us what other topics you want us to cover. So we've just built our lineup for 2025, and you can see that on the right side there. There is a different link to use to sign up for 2025. So if you signed up for a bunch in 2024 all at once, that won't get you invites to the 2025 one. So there's a new link on our website, or you can do the QR code on this if you so desire and read about the topics that we're going to cover next year too. All right. I think that's all I got, Christy. I'll put the intake in the chat.
Okay.
All you.
Thank you. Thank you. Okay. I'm Christy Blakely, and I'm a senior advisor with Family Voices Colorado. I'm also the proud parent of a 42-year-old daughter, Lauren, who uses a wheelchair and technology to communicate and is very medically fragile. She lives in her own place with a significant other, Mitch, who also is in a wheelchair and uses a communication device. I also am proud grandma to 3 kiddos, 9, 7, and 3. I'm going to point out in caregiver conversations, one of the really important things that is coming down the pike is the July 1 start of Community First Choice. We're doing a presentation June 5th. It's all the changes that are going to be happening July 1. So please pay attention to that. If your kiddo's on a waiver, there's going to be some changes, and there's going to be some good changes related to consumer direction. So, but we want to keep you all up to date and informed. There's a lot going on social media about all of this and what's changing. And services are going to change, not in a negative way, in a more positive way, but we want to communicate that. We have some objectives tonight, and those are to understand Health First or Medicaid's EPSDT benefit and policies. EPSDT goes up to 21, so the 21st birthday is when it ends, and we're going to utilize some case studies to demonstrate how it's implemented. We're going to understand how to initiate those benefits. If you say something to your provider, your doctor, like EPSDT, they're going to look at you and say, you don't know what you're talking about. And I'm going to tell you, after this hour-long presentation, you're going to know more than your provider does about EPSDT. And it is a federal mandate. It is critical for our children and adults to access EPSDT through their Medicaid benefit. So we're going to understand how to get those benefits, and then we're going to understand how those waivers work with EPSDT. So EPSDT stands for early. We're talking about assessing and identifying concerns early. Periodic, checking children's health at a periodic. And I've put in the AAP's periodicity screen. You can schedule, you can go and Google that, but it's how often kids are supposed to see providers, and it gives the vaccines, et cetera, that are supposed to happen. But that periodic screening is supposed to then identify that screening. So a screening is a head to toe, physical, mental, developmental, dental, hearing, vision, all of it. And it's supposed to identify any concerns, because if we diagnostically treat and then diagnostic, find, and then treat, early, it's a cost saver. And we do this for children in Medicaid because they're at risk, and a more vulnerable population. So screening is physical, mental, all the things. Diagnostic is performing any tests to follow up when a risk is identified. So in Colorado, we all do the ASD evaluation. When you go into the doctor, there's a piece of paper that comes to you that says, is your child talking or walking or doing all those milestones? It's to help the provider identify, and those are funded if you have Medicaid, under Medicaid. So diagnostic also is blood tests. It's blood screening, lead screening, because many of our kids in Medicaid live in still housing that has lead paint. Diagnostic, and then we do the treatment, and that's to correct, control, ameliorate that health problem that was found. So at one point, the legislature at federal level was wanting to get rid of the treatment because they were going to save money. And those are the kinds of things we watch very carefully, because we don't want to lose the treatment, because then we'd be saying, yeah, there's a problem, but no, we're not going to treat it. And that doesn't make sense. So I'm providing for you all sorts of links. And so there will be the presentation available, and it's already in the chat. So we're talking about best practices and early periodic screening, diagnostic and treatment. We're also talking about the EPSDT fact sheet. EPSDT is very well understood on the Colorado Healthcare Policy and Financing website, HCPF, and that is our Colorado Medicaid agency. And the rules and regulations are 8.280. So we really are trying to help you be able to look for those things. But EPSDT, again, federal mandate. That doesn't mean the state decides. The state has to offer EPSDT if it's going to offer Medicaid in the state of Colorado. The same as McDonald's has to offer the same French fries, whether you're in Europe or here. Anyway, that was just fun to think about Europe. Anyway, early periodic screening, diagnostic, and treatment not only is a federal mandate, and it says 0 to 21 children are eligible. So when we think about that, we also often think, well, 18, a child goes to an adult waiver, and they move to a adult home and community-based waiver. They still have 3 years of EPSDT. So during that time is when we want to get new equipment. We want to make sure those wisdom teeth are in place, because a lot of the flexibility that EPSDT offers us for children up to 21 goes away on the day of their 21st birthday.
I throw my 2 cents in there.
Yes, please.
I started already having, my kiddo is 12, and he wears hearing aids, and we started having a conversation with his audiologist right now, planning out when he's going to get new hearing aids, the next pair, and then so that we're timing it so he gets another pair right before he turns 21, before EPSDT ends, because that's when he will have the best benefits. So even if your kids aren't close to 21, you can do some strategic planning now.
And that really is critical, because as a navigator advisor that does the adult world, if I can get somebody at 18, I can get what they need. At 21, it's a much harder process. So just know that, and know that you need to pay attention to that. Okay. So when we talk about EPSDT, we are not talking about a separate eligibility. I often talk about the Medicaid house and say you can go indoors or windows or whatever, but if you're going in a waiver, you go in one way. If you're going income-based, you can go in another way. It's not a separate eligibility. EPSDT is the children's benefit package, 0 to 21, of Medicaid for children. So no application, no special bucket of money, no separate release information, but it offers flexibilities that you may need. Now, Medicaid will tell you, just ask, just have your provider ask. Well, if your provider doesn't understand EPSDT, they're not going to feel comfortable asking. So a lot of times families need to speak up and say, this kid has Cigna or Blue Cross or whatever the insurance is, primary, private, primary, and then Medicaid secondary. So they're eligible for EPSDT. There is a place in the portal where they bill to say this is an EPSDT benefit, or they can say EPSDT because of the age range. But we need to get providers better informed. And I've been doing this for almost 35 years. And I'm still wanting providers to understand it better. So we talk about fee for service versus EPSDT. There is components of fee for service being billed straight to Colorado Medicaid. EPSDT is just a mandatory part, not a separate checkbook, no limits. And that's one of the big flexibilities under EPSDT. No hard limits. So if you know, if somebody says, oh, you can only have 8 of something, that's a hard limit. You can't say that for a child. Medically necessary is the answer of what we're doing. We're going to correct or ameliorate the issue. And there's no hard limits to that. So all services must be provided. And then there's this wraparound RAE contract, regional accountable entities. You typically get into the RAE and all of that if there's a mental health issue along with an intellectual and developmental disability. We'll talk about that more. There is a definition for medical necessity, and I'm going to tell you the words to use and not use coming up. All right. So EPSDT allows for these flexibilities. Okay, we're going to go to a case study. Yeah, we're going to go to a case study. Oh, yeah. All right. 12-year-old has been violent behaviorally with the family members. Police have been involved multiple times. The child going to the hospital on a mental health hold. Child also meets the definition of developmental disability through an adaptive behavior score. What are we going to do? And how are we going to use EPSDT? I'm not going to ask you this answer. I'm going to just give it to you. So under EPSDT and Medicaid, we have such a thing as Creative Solutions. Creative Solutions now is run by your regional accountable entity, and they facilitate the calls. And these are team calls with everyone that's involved in the child's case on the call. So we have everybody from schools to juvenile justice therapists, hospitals, whoever is involved with this child. Obviously, the parents or caregivers. So we talk about this because we have a lot of kiddos with intellectual and developmental disabilities that also have a mental health diagnosis. Sometimes it comes earlier, sometimes it comes around puberty, but that getting angry, getting violent, this system of Creative Solutions, and you ask on a case-by-case basis, but it is a way for us through the regional accountable entity to get everybody on the same page and to come up with some creative solutions about how are we going to support this family and this situation. So that, that could mean many different things. But know that these creative solution calls are teams of professionals along with everybody on your kiddo's case that are all talking in the same place about what are we going to do. And oftentimes we're doing placements for these children, but it is part of the RAE's responsibility to facilitate these calls. So depending on who your regional accountable entity is, which you can look up by writing in regional accountable entity in the state of Colorado. I should have put a link there. All right. But
I put a link to the RAEs in the chat.
oh, good. Thank you. So we really are talking about everybody involved in this child's case. And sometimes these cases go years. Sometimes they go a few months, depending on what the solution is, depending on the level of need and problem, but and challenges with the kiddo. But EPSDT created the creative solutions meetings and then handed those down in a responsibility to the Rays to run. And so it's a way for us to address these children with dual diagnosis. Okay, spent maybe a little more time than I should have on that. So let me move forward. So if the services aren't available in Colorado, EPSDT has the flexibility to provide not only out-of-state treatment. So in the creative solutions world, we can send a child out of state for a facility if we've exhausted everything in state, but also it gives us the ability to pay to go out of state if you can prove there's no service in state. So an example would be a high-level feeding clinic for your kiddo that's a failure to thrive. EPSDT can do a daily rate. They can provide assistance with transportation, all the things. Is it a lot of paperwork? Oh, yes. Nothing happens with the state that isn't a lot of paperwork, but it is doable. And it often comes with the need for like a medical provider to say, please, this child needs this, all those things, but it is available and it is a flexibility. So just know it's available. Okay, here we go. 4-year-old with multiple disabilities needs a third pair of glasses in less than a year due to extreme wear and tear. This is where I'm going to look in the chat. What's the answer, people? I'll wait.
I feel like we need the Jeopardy music. Do, 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 do.
Okay, nobody's going to play. This is not fair. Are you all putting children to bed? What's the deal?
No, it's one of those nights where everybody's off camera. It's a snow
Okay,
night.
I'll just give you the answer. Never mind. EPSDT has no hard limits. So it doesn't matter. Yay, Corinne. Yay, Corinne. Yay, Corinne. EPSDT has no hard limits. So even though your child has gotten a pair of glasses, that does not mean they can't get another pair of glasses because EPSDT says it's medically necessary for the child to have glasses. So understand we mean this related to everything. So if you think, oh, we can't have another communication device because we've had one and it's been less than 5 years. No, not under EPSDT. But we have to prove why we need another one, why the one we have isn't working, or if our language has improved enough that we've graduated to a different level, whatever the issue, children change. That's the whole bottom line to EPSDT. Kids change. So in the state of Colorado, it is defined because it's not federally defined, so it's state defined. And this is what they talk about: to correct treatment of services to correct or ameliorate defects in physical and mental illnesses, conditions identified in the screen. So we're talking about maintenance or improving services, and we define medical necessity. And I'm going to show you what that looks like, but there is a defined medical necessity. I see Sabrina said, add to confirm this changes at 21. So yes, EPSDT goes away the day they turn 21. These flexibilities go away. So you become a full adult. I don't know how to say it because at 18, you become an adult in the state of Colorado, but at 21, you can drink, but you no longer can have your teeth cleaned. No, that's not completely true, but there are definitely changes. So medical necessity is uniquely defined. So we're going to go there, but hold on a minute. What do you do at that point to have needs met? Well, the needs should be met, Sabrina. I mean, depending on what it is, medical services will be provided. There will be limits. So for example, right now, over 21 speech therapy is not covered for adults. We've been fighting that. We've asked for a piece of legislation this year or a change to that policy because we see PT and OT being covered, but no speech. So we're fighting that, especially augmentative communication. But they still will have Medicaid. They still will have services. It's just these flexibilities for children go away. So you don't get multiple glasses as an adult. So there are certain things that are prohibited, and this is an example legally, because it's a federal mandate, no service caps on those hard limits. You do sometimes have to have prior authorizations done, but EPSDT will cover unless it's experimental. And so that's where we get into some of these orphan drugs or unique new drugs that are very, very expensive. Oftentimes, even EPSDT will say, oh, that's experimental. So we have to really work to show that scientific evidence. We have to show cost effectiveness. I'll give you an example. Cost effectiveness would be, for example, a wheelchair seat that goes up and down so that the transfer of a larger individual would be across to the changing table versus lifting them. And we could say, oh, that's caregiver convenience, so they don't have to lift. That would be denied. But if I said, no, 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 it has to do with safety, so we don't drop the individual that's quite big, oh, then it's medically necessary. So we really have to think about what is medically necessary. And I'm going to tell you the language to use and not to use. But we can't in Medicaid deny just due to cost. But they can say, wait a minute, well, if that stroller is $6,000 and this stroller is $5,000, why aren't you getting the $5,000? If we can prove medical necessity in the bells and whistles or the things that are the words, the things that make it best for this kid or more usable for this kid, then we can say the $6,000 one's the one we want. But they're not allowed to say, no, that's $6,000, we're not going to cover that. You have to prove it. Nikki, you've come off mute and on camera, so I'm guessing you're going to ask a question.
I just finished eating dinner.
Oh, okay. Well, it's always nice to see a face when I'm talking like this, because otherwise I feel like I'm in my living room just talking, right?
I so agree. I always hate talking to a blank audience.
So thank you, Nikki, for being my face tonight. Okay, so here's the language that Medicaid uses. It's reasonable, it's appropriate, it's effective. So, you know, we're looking for something that works for the child, and we sometimes need to prove why it works for the child. And we're looking at it in current medical standards. And that's where we get into that experimental. The cost effectiveness is less important if we can prove the reason we need this one over that one. And it is no different in our world than going to get a car. You're not going to get a 2-door car for a family of 6. Right? I mean, you're going to do all the looking and figuring it out and everything. Families have the ability to do that and really know what they want and why. And that what they want and know and why is what we put into that letter of medical necessity. We also want to know that it's safe for the environment or the situation. So we're not going to provide a kid, you know, some sort of a large power wheelchair if nothing in their life is accessible, right? We need to make sure that we've got ramps into the house or the accessible van, all the things that go with that. And of course, Medicaid doesn't cover the accessible van. Just don't even think. That's only in Minnesota. Okay. medical necessity is not experimental or investigational. We get into that a lot with those orphan drugs. We get into that a lot with the seizure medications. It's not to enhance the personal comfort of the client. And this is honestly, this is language that Medicaid's come up with, and they'll tell stories about, oh, the hot tub that somebody had to pay for. It's really more about the medical and not the convenience or the comfort. So we're talking about medical. And then the convenience of the caregiver or the client's caretaker. So if you say, I need a lift so that I don't have to lift my kid, that's convenience of the caregiver. If you say, to be safe, this kiddo needs a lift, then you've got not convenience of the caregiver, but safety of the individual. So you just have to turn it around and check to make sure that you're thinking it the right way. And then to take the place of clinical guidelines, it's got to be within those guidelines. So if medically people aren't going to do it, and this is where we kind of got the rub with the whole medical marijuana thing. So it still is an issue, but less so. I see more of the experimental denials, and I see more of the caregiver convenience because we wrote it. It's really hard to think about the child and not the parent caregiver. So when we're justifying medical necessity, and these letters are often requested, these are the things that need to go into it. All of these things. So the full name, the name of the parents, the data, all the things that relative diagnosis, look those up online, item and services requested, and why. What is it? I always use brochures, pictures, whatever to tell, because the person who's deciding this is in some cubicle and doesn't understand half of the medical stuff that you parents do. Okay, we parents do. Okay, the positive and negatives of this, including the financial. If this one's more expensive, but it has, better straps for your kid, or something for head control, or something for side chest. Communicate that. Tell us everything that makes this one better. Scope and duration, like we're looking at this for the next 5 years. Kid may outgrow it, but that's what we're typically going to say, 5 to 10 years, something like that, even if we don't think they'll last that long. Any kind of pictures, letters, articles, anything that you could come up with. And then identify any funding streams. So if you've gotten a letter of denial from, say, your insurance company, put that in there, because Medicaid then pays attention to that. I had one case recently where we were appealing, but the private insurance was paying everything but 2 pieces of an adaptive stroller for this baby. Like, it was not even a significant amount of money, but Medicaid had denied. And I literally called Medicaid and said, I think I was maybe drunk that day. No, I'm joking. But I literally called and said, Medicaid, why are you denying this? The private insurance is going to pay everything but these 2 items. Come on. I literally did, because I did not want to appeal it for a baby that's going to change significantly by the time we get to trial and all. So I was just like done. So there is wiggle room. There's communication that can happen, but justifying medical necessity is critical. Understanding what's medically necessary, what's clinical, promoting that independence, preventing any secondary. And that's what I'm talking about, dropping the kid. So the raised seat, and it's a lateral move, isn't caregiver convenience. It's keeping the kid safe, right? And if I've got an easier diaper change on a middle schooler, I have less chance of having skin breakdown, because they're not going to sit in the diaper. We're going to change it more often because it's easier. But I'm not going to say it's easier for the caregiver. I'm going to say it's better for the kid and the skin integrity. So thinking those languages. And then we're going to talk about cost effectiveness and safety. And then don't talk about custodial, don't talk about rehabilitative. We don't like developmental delay. We use disability or intellectual and developmental disability. Speech delay also doesn't, it doesn't compute with coding in medical world. Use a diagnosis like aphasia. And then if it's educational, Medicaid won't cover it. And if it's caregiver convenience, not going to cover it. So just know what language to use and what not to use. So ask yourself, and I got caught on this literally about 4 years ago. I do this presentation. I know this stuff cold, and I still forgot that Lauren needed a speech therapist to give us a recommendation for a communication device, even though she's been on one since she was 5 and she's 42 now. But I still needed a speech therapist to give us the recommendation of which we should use. And so I caught myself by looking at this list. Is there a licensed provider writing the statement? Is it medically necessary? So go through this list. This should be your checks and balances as to, have I done everything right for this letter of medical necessity? And Medicaid continues to say, just ask us. Well, I'm going to give you the name of the person that's in charge of EPSDT at Medicaid. Her name is Gina Robinson. I'm going to give you her phone number tonight. And she's the one we go to. She's the one I go to. I text with her like, why won't this get covered? It should get covered, all the things. And we're often like that old cartoon where the one person is trying to kill the other one and they just kind of punch out. You guys are too young for that. Never mind. Anyway, I don't know the name of the cartoon, but it was like a coyote and something else. Anyway, all right. So understand that there are things that are covered under EPSDT that aren't covered after into adulthood, but often we know that we can ask for these things, but things like, I would much rather have you come before 21 to me and say, we need dental under anesthesia before 21 than after 21. It's easier to get. There's more flexibility. Okay, don't forget EPSDT covers everything: dentistry, pharmacy, vision, right? So no hard limits on medications, on the vision stuff, on the behavioral health. We have many home and community-based service waivers in the state of Colorado. We have children's waivers and we have adult waivers. So I'm just kind of going over this to let you know that there's going to be some changes coming, like the children's HCBS waiver. Whoops, didn't mean to go there. And the life-limiting illness are going to merge. Is that July 1 also, Megan?
Yeah, it's gradually between July 1, 2025 and July 1, 2026. So whenever your renewal is in that year.
Okay,
period.
so families that are on one of those waivers are going to go to this new waiver as, over time is kind of how, because they can't do everybody at once. So those things are going to change, but the waiver services won't change. You're still going to get the services that are in that. It's just going to be one waiver. That reduces the burden on the state of Colorado, honestly. So that's a good thing. Okay, Roadrunner. Thank you, Megan. All right. The waiver services have already been approved under Medicaid, under CMS, Centers for Medicaid Medicare Services. And EPSDT is kind of, it's hard to explain because it's not a separate bank account. It's not a separate checkbook, but the waiver services are over here and authorized under HCBS, where Medicaid and EPSDT sit differently, separately. But if you go to the hospital, you're not going to see the difference. It's Medicaid's going to cover what your private insurance does, and if you have a private insurance. So just know that there's always a way to access things. If you're not sure how, ask. And you can ask Family Voices, you can ask Gina Robinson, I don't care who you ask somebody about what, but we shouldn't hear, if it's medically necessary for children under 21, we should not hear no. If you can prove medical necessity, we shouldn't hear no. That's what I want you to hear. Okay, I'm seeing somebody that's come on. Selena, are you wanting to ask a question? No, you're just giving me a face. Thank you very much. I appreciate that more than you'll ever know, because it's hard talking to yourself. Okay. I love this graphic because it helps me picture how Medicaid works. So everybody on Medicaid is on the state plan Medicaid. That's what Medicaid offers in the state of Colorado. Then just above that is long-term care. And this is where we continue to tell Medicaid their letters don't make sense. When they send you a letter on the home and community-based service waiver, then they'll say you're approved for long-term care services. They don't tell you you're approved for this waiver. They say long-term care services. In their mind, in Medicaid's mind, that means home and community-based services. To us, that means I don't understand. So long-term care equals home and community-based services. It also equals all the other programs that provide for this higher needs population. And that's that blue area. And then we go one more step, and those are the home and community-based waivers. And they're the smallest population. They're some of the neediest population because they're some of our most disabled. And, you know, we should celebrate in the fact that we have an amazing home and community-based service waiver program in the state of Colorado, the most waivers of any state in the country, and we provide for the most people in the community, all of which is very, very important. So we also, under those HCBS waivers, bring people out of nursing homes if they're living in nursing homes to go into the community. And we also provide that consumer-directed attendant support service, either in-home support services or CDASS, consumer-directed attendant support services. So all of which is to say you have to go through the state plan, which is the basic benefit package, along with EPSDT if you're under 21, into long-term care to get to the HCBS waivers.
You have a question in the chat that are waivers protected federal and state, or how are waivers?
So Sabrina, that's a really great question. And as we go into a legislative session in January that is talking about $500 million to $1 billion in deficit, home and community-based services come out of the federal government, but there are flexibilities given to the state on how they want to do the money. So the waivers are not, they're optional benefits. They are not mandatory benefits. So they're not necessarily protected. And the CMS federally says, yes, state Colorado, you can have this many waivers, and we're authorizing all of those. But if our legislature says, you know what, we're going to get rid of this X waiver, and I'm not trying to be scary, I'm just being very honest, we've seen legislative sessions like that. And so as we begin to watch now with the election behind us, what's going to happen, we're going to be working to keep the services we have and not lose anything, honestly.
Yeah. The federal government says you can, and Colorado has said we will, but that doesn't mean anybody has to, which is hard.
And Sabrina, to answer your question more, it's a federal match. So the waivers give us a federal match. So if it's about 50 cents to the dollar. So one of the reasons we have the waivers is because we're saving the state of Colorado 50% of the cost of that individual in the community. At the same time, Colorado has to spend 50 cents to provide for that individual so that this federal match happens. So that 50-50, if Colorado doesn't have that 50%, then you lose services. So we're really going to be watching, and the legislative policy people are already starting to look at, you know, what's on the agenda and what's going to get cut, because something's going to have to go. We can't keep what we have or add to it if we have a deficit of $1 billion. That has to come from somewhere. So I didn't mean to get into all that, but it's the real deal. Okay, here's our next. I don't want to give it away. Wait, so they're protected at the state level, so anyone can. If there's not the money for it, yes, we could lose them. Yes, if there's not the money, and we've had legislative sessions like that. 2004 was like that. We had to go to the Capitol and say, don't you dare take those HCBS waivers, because they were targeting children's waivers at that point, because we had waiting lists too. So
Yeah,
yes, but at the same time, families are the largest caregiving population in the state of Colorado. And if that went away, the state of Colorado would be, I mean, that's not going to make good press. So do I think they're going to go for the HCBS waivers? No, not this year. No, because I think they figured out that we're a strong voice. Anyway, so we're, but yes, if there's a battle cry, we'll let you know.
Yeah, they put out their budget request for this next year, and it's mostly cutting the rates on some of the services. Not cutting services entirely, but like enhanced homemaker that's on CES and SLS, the rate is getting cut by like 10% and some of those things. But there's so many moving pieces in this next year that it's hard to parse out what's what in terms of how it'll impact.
Yeah.
But so far, they're planning to just reduce rates.
Yeah. And that's a good place to start in reducing, but our rates aren't that fantastic already, right? And that's cutting into families' budgets. So we are going to have to be vigilant. Okay, case study number 3. I'm sorry. Now I've got to look to see. No, I'm Sabrina, you're good. This conversation needs to be had, and it's going to be had a lot more. So just know that it's what is keeping me up at night, having been through 2004. Okay, case study number 3. You guys are going to get this. I know you are. The family's private insurance only covers 10 therapy visits per year. The family just got on the Medicaid buy-in and wants to know what limits they have on Medicaid for OT, PT, and speech. Yay! Maggie did it. Yay! Kaylee did it. There are no hard limits. And if your private insurance does 10 therapy visits, great. They will go there. And then after that, they'll say no more, and Medicaid will start picking up. And Medicaid doesn't have any hard limits. So it's just, you have to keep the private insurance and the Medicaid separate. So good job, guys. So the first 10 are on the private insurance, and then after that, Medicaid steps in, and yep, there we go.
But you can have both, right? I've seen a lot of questions about that lately. Private and Medicaid.
You can have private insurance and Medicaid. That is the best coverage you can do for your child.
Mm-hmm.
Absolutely the best, because private insurance pays better, has more doctors available, right? And then after that, Medicaid picks up the difference. You don't have balance billing, and you don't have copays. So the family wins and the providers win. So we really encourage families to keep private insurance. We carried Lauren's private insurance into her late 30s, and then had to drop it because Medicaid and my private insurance could not get formula correct, and I wasn't able to feed her. And there's a problem when you can't feed a G-tube kid, there's just a problem. So yeah, I had to give up my Medicaid or my private insurance because they weren't communicating. Let me look at this. Primary, secondary coverage explanation is a great one. Thank you. Okay. And would a child who does not qualify for Medicaid still get unlimited therapy OTP? No. This is EPSDT is the children's benefit package under Medicaid, 0 to 21. So if you don't have Medicaid, you don't get it. But kiddos can either do buy-in, Medicaid buy-in, then you get it. Or you can do an HCBS waiver and get Medicaid, and then you get EPSDT. You do not get EPSDT under CHP plus. Another reason why CHP plus is not the best benefit coverage for our children with special needs, because it acts just like a private insurance and doesn't have all these flexibilities. Okay. The regional accountable entity is is different than your case management agency. Your regional accountable entity, Colorado, in Denver, it's Colorado Access. In other parts of the state, it's help me.
Colorado Community Health Alliance in
Thank you.
El Paso County.
You guys are
Rocky Mountain Health Plan.
Thank you. So the Rays came on and they were given some assignments, including some EPSDT stuff. The case management agencies are over here and they're supposed to be doing the long-term care services and intellectual and developmental disabilities and all of that. We ask, where do they come together? Where's the overlap? Who's checking on whom? And what we found out is really they kind of work like this. They don't work together. And so we've kind of gone in and said, we need to do more coordination. We need to do. And so oftentimes you'll see Array facilitate that creative solutions call I talked about without checking on the case management agency that might be working on the waiver. So we need to keep that. This is a Venn diagram. We need to keep that center area and keep remembering that, wait a minute, there's other entities doing this work with us, and make sure that they're all at the table. Okay, Julie's asked, would a child who does not, oh, I already did that one. Oh, good, I'm caught up. Okay. This is a biggie because we often get called about appeals, and the first thing is the family says we were denied. That's helpful, but we need to know why they were denied, because that's the reason, that's the problem. What was it that got denied and why? And it's always on that letter that says, they were denied because of medical necessity. Well, then we've got to know the definition of medical necessity, or we really don't know why they got denied. But there is an appeal process. It is time sensitive, but there is an appeal process. Family Voices does those appeals. There's others. There's an attorney, Jack Robinson, that's doing these appeals. But know that you have the right to say, whoa, back, let's go back and let me tell you why this was whatever it is. And the example of the stroller, I could have gone through a full appeal process with that one, but I was like, it's a stupid decision that they're not covering it because private insurance is paying more than their share, honestly, of this device. So those things happen behind the scenes, but also there's the full appeal process in front of an administrative law judge and all the things. It's like a mini court. Okay.
You have another question in the chat. Are there particular circumstances when you tap EPSDT versus requesting funding from a case management agency?
Okay. Those are from Nikki. Nikki, those are two different things. So if I need more respite, or if I need money for hippotherapy, or I need additional money because my husband's going to travel and I need somebody to help me at night for 3 weeks, or whatever the thing is, I'm going to go to my case management agency and ask for family support funding or mill levy if that case management agency has mill levy for those kinds of needs. What I'm going to go to EPSDT for is something like a piece of equipment, and my child for some reason needs an extra device and they've denied that device because they don't understand the medical necessity of it. Say it's a halo to hold the kid's head, or a neck thing. I mean, wheelchairs come with all sorts of equipment. The other time you're going to go tap into EPSDT is the kiddo needs a behavioral health facility or services out of state. or in-state, because we can cover more EPSDT behavioral health. We can cover more behavioral health funding through EPSDT up until 21. After 21, it's more limited.
Yeah, I think it gets that line between like medical necessity. So like medical necessity comes first, and EPSDT is medical necessity versus case management agency funding is what do you need to live in the community versus in an institution. And that gets really blurry with a lot of
it does get really blurry. You know, I've done EPSDT things on a titanium rib that it was a kiddo with very unique physiology, and he needed a titanium rib that was going to grow with him. And that wasn't on the Medicaid benefit plan. And so we had to go to EPSDT. EPSDT is for that extraordinary, but it's also for those hard limits.
Yeah, the reason I ask is there seems to be like some blurred lines, like dental coverage, for instance. If there's a procedure, I typically would have, it goes through primary first, and then any leftovers has been through my CMA versus EPSD. So I don't know if that's typical but there's been different situations like that too for even like equipment stuff that's medically necessary. So I was just curious.
Absolutely, dental can be EPSDT. I'm working on a case right now where the private insurance doesn't have, you know, it's kind of in the weeds and I can't really disclose, but I bring in EPSDT if I hear no. I bring in EPSDT if I'm left with a bill that's not covered. I'm going to call EPSDT and say, wait a minute, if the kid is not 21 yet.
And usually case management agencies, not always, but usually they will, if it smells a little bit of medical, they'll ask for a Medicaid denial before the case management agency will want to pay it. So case management agencies are lower on the totem pole, or they want Medicaid to pay first. They're after Medicaid, straight Medicaid pays. So if they think it may be medical, then they might ask you to get a denial.
Interesting. So same thing with blood work.
Yes.
Should be primary insurance, Medicaid. Then if Medicaid is denied and denied and denied, and EPSDT has been tried and denied, then the case management agency would step in.
And I can't imagine why blood work would not be authorized. If it's like too soon or something like that, I would be going to EPSDT. I'd be saying, have you billed EPSDT on this?
Yeah. I think it's more what you mentioned from the onset, more of a provider lack of knowledge that I'm dealing with. And
especially your dental and vision. I mean, I literally have gotten calls from children's ophthalmology saying no to multiple glasses for a kid, and they don't know about EPSDT. And I'm like, no. And so I sick Gina on them, honestly, because of everybody, children's eye stuff should know. So there are particular instances, but if it's medically necessary, it should be EPSDT. The other thing is, no, if you have Medicaid, you should never pay out of pocket, ever. If you get a bill, you call them and you say, I have Medicaid. This is not something I'm going to pay. You should not be billed. If the provider doesn't take Medicaid, then you're going to have to pay. So if the dentist doesn't take Medicaid, then yes, you have to pay after the private insurance. Right? This gets I mean, we become amazing advocates just as parents. Okay.
And a way I've gotten around some lab work stuff through specialists that are not covered by Medicaid is just I have a good relationship with the pediatrician. I just go to the pediatrician, and if it's something that they don't immediately feel comfortable because it's some really specialized blood test, then I give them justification. I give them the articles or whatever justification for it. But most of the time, my pediatrician has been completely fine with ordering whatever is needed to be ordered by a specialist that's not covered under Medicaid. And I also wanted to say something for EPSDT that I was completely stunned got covered for us a couple of years ago through Children's doing like they didn't have an issue, and I was really surprised. Genetic testing, why it wasn't genetic testing, but my kids have a specific genetic disorder, and there's this specific test for another genetic condition that's different, but on the same similar area of the gene. And it could have, it was a test of predictive factors for, and Children's got it covered, no problem. And I was really, really stunned because it was really experimental. It was not proven, especially for
Wow.
my kid's condition. It had never been done on my kid's condition before. So, yeah.
Interesting. Okay, so we have no hard limits, no caps. We know that this is state, federal. EPSDT is a federal mandate, but the state defines it. And that's why we have caregiver convenience and some of that other language. Some states don't even use EPSDT or even have it. So we're good in Colorado that we actually know EPSDT and can talk about it and use it. Know that it's anything within the state plan or beyond. So I think of the state plan as the contract with the state of Colorado to say you're going to have Medicaid. Okay, then you also have to provide EPSDT. There's a limit, there's a service plan of what's state plan. And then if it's something outside of that state plan, EPSDT is when that gets covered. So EPSDT is up to 21, not CHP plus, because that's not Medicaid. And we do have case management and outreach. So there is Gina Robinson's actual phone number, actual email, and she is the state EPSDT person. So, you know, today I texted her and asked her about a kiddo that I thought something should be covered. And a lot of what I do now is mental health and behavioral health. And I often think it should be EPSDT that does that. And she may push me back to the Ray, but at least I've had that conversation. So know it's available and should be utilized. And especially for our kids, honestly, because our kids often push the envelope.
Yeah.
So
I think there's some other weird, like hippotherapy being covered now. Like that makes sense under EPSDT that should be covered. And it took legislation to get it in policy, but it should be covered. We've also had weird things like we had a weighted vest covered by EPSDT when he was little. And I didn't think that would be, or those like fancy spandex custom Speo suit things
yeah,
that we got EPS that we didn't have to use waiver money for. We could use EPSDT for, as long as we got a provider that was really good about being willing to bill and do the paperwork to prove medical necessity.
yeah. I think, I mean, I in a little bit, I'm in Nikki's camp saying I wish it was clearer that, oh, this should go to case management, or this should go to mill levy, or this should go to Medicaid, or this is under EPSDT in that funding piece. So, you know, as we try to navigate what's available to our kiddos, we often are bumping up against really who's going to pay for that. And I don't know any other way. I mean, historically, I know what has gone before and what should, but I don't know that there's any way that we could put that in hard print, because I don't think there's any straight answer to what I'm asking, honestly. But I'd like it.
Yeah.
I'd like it on a piece of paper.
Christy,
So-
one thing I hear a lot is about over-the-counter medications that a doctor might prescribe. And sometimes I've seen Medicaid cover and a lot of times not. And I can't figure out and what areas they consider it EPSDT and when they consider it like normal.
You know, it used to be
parental
over-the-counter medications were something that EPSDT covered.
And some like Miralax they'll cover, and that's over the counter. But what was it? Senna. We could get Miralax covered, but we can't get Senna covered. And I'm like, really?
Yeah.
And I
Yeah.
can't figure out, maybe we need to hound Gina about that. I
Well-
think I tried asking Gina and she was like, have them try and sometimes it'll go through. And I was like, no,
You
no,
know, I think what we ought to do is put that on the Children's Disability Advisory, topics, because I think that's a topic that a lot of families really struggle with. I mean, we pay for Miralax for adults, so I don't even know if that's an EPSDT thing versus a Medicaid thing.
It should be a standard and not playing roulette. Let's see if it's covered this time for
Yeah,
this person.
right. No, I totally agree.
Also,
Totally
the kids that have midazolam as their seizure rescue med, that they'll cover the midazolam, but they won't cover the thing that makes it where you can actually administer it.
Spray
But
it.
under
Spray it up the
EPSDT,
nose, correct,
yes,
yeah.
they should,
Well,
but then it costs $20 that you need it not very often, so then it's often just not even worth the fight. But
Well, and another place EPSDT comes in is on the seizure meds where it says you have to try this med before you can have this more expensive med. EPSDT will make that go away so you can get the more expensive med. But in the adults, you have to do the trial.
I was gonna say we've had it too where like the prescription was written once for like the name brand and then the next time it was written for the generic and like it would cover one but not the other even though they were the same medication, like name brand versus generic. That's kind of come up for us too several times.
Yeah. And some of those nuances are, I mean, that can take all of your brain cells. I mean, especially as busy parents, I mean, the specifics and what does work and doesn't work is crazy making today because it's never consistent. I'm not helping things, I know, but it just feels very overwhelming to me to look at what's going on today and what parents have to do. It makes me very sad. So let's answer other questions. We've kind of gone all over the board tonight, but I think it's been a good learning. And I think you now know EPSDT and what it stands for, even if you don't get the letters in order. Know that it's there for your kid until 21. What else? What else can I do for you tonight?
something else altering is sometimes there'll be things that get denied a lot, and then once we get it approved for a couple cases, then it kind of paves the way for it to be approved. Like for a while, Medicaid was denying like the nicer medical beds, saying like this is a convenience item, this has all the bells and whistles, you don't need those. And then once we got some really good letters of medical necessity in and got a couple of them approved, now they're approving it for most people. So some of that is like you have the opportunity to pave the way for your kiddo and or your adult and other people's too.
You know, and part of that, honestly, is the people that are looking at these letters and this information don't have any history, knowledge, experience about what we're talking about. And so it is like going to the gas station attendant and explaining your kid's genetic condition. They're going to look at you like, what? You know, because you're out of the blue just talking about this to them. And that's kind of, I picture these people in little cubicles with no background and going, you know, we used to have there was a talker like a macaw or something like that. And I literally had somebody call me and say, they really want a bird. I literally did. I honestly, honest to goodness did. I was an Easter seal. This was in the 90s. I was like, no, they don't want a bird. That's the name. And then all the devices changed, seriously, in history, changed to the names of cars, Pathfinder, and all these others. But it was crazy. At one point, they were all like birds. Macaw. There was something else. Anyway, yeah. So just know there's this historic that we've been fighting this. We're going to continue to fight it.
We've got another one. So when the primary denies and that denial gets sent to Medicaid, how do we educate people on those sorts of people? Can you talk more about that whole process when you've got both?
Say that again. Help me.
Yeah, when your primary insurance denies something and then they send that denial to Medicaid, how do you make sure that that goes through from there, or make sure that process happens to where it actually gets approved by Medicaid in the end?
Well, I mean, it should follow with a prior authorization. I mean, depending on what it is, there's different processes, but if private insurance is denied, then Medicaid should pick it up.
Yeah, I think the
And
only time I see
EPSDT
that,
should step in if it's something outside of state plan.
yeah, I think the issue, if primary denies saying like you didn't do the paperwork right, Medicaid's not going to pick it up. But if primary denies saying we don't cover that, then Medicaid should.
Yes. And if they don't, call Gina Robinson.
Yeah.
And I mean that. I mean, or call us and we'll call Gina Robinson.
Yeah. Oh, and she said for pharmacy in particular, pharmacy will put a over the counter in, the primary denies it, and they don't even know to submit it to Medicaid.
Then tells them to submit it to Medicaid.
Yes.
I mean, show both cards.
And they should be doing that with all medications. If your primary has a copay, they should be submitting it to Medicaid that will cover the copay. So
yes. Yes. Otherwise, you're going to be stuck for the copay. Yes, it should be that easy, Nikki. I know it should be that easy. And I want more transparency in EPSDT in Colorado. I really do. Especially in the mental health IDD world, because that gets, so convoluted. But the way we have things right now, we don't have the amount of transparency I'd like. And Gina really does hold a lot of the purse strings. Not really purse strings, because it's not the money, it's authorization. And that's why she continues to say, just ask, just ask.
Yeah, I think so the federal government came out in September with this whole 57-page document telling states to do better with EPSDT. So still early, but hoping that will make some progress in these things being not as frustrating.
I think there's a lot of families who have unknowingly been leveraging EPSDT benefits. And then when you kind of run into a barrier, don't necessarily know to ask for it. So I'm just kind of curious, like how the education piece, like how we can better educate families what to ask for. And it just really isn't out there.
Things like this.
Yeah, I totally agree.
Things like this evening. And, I literally have spent time traveling the state, talking about EPSDT, helping providers better understand, working with RAISE to have them understand how people, there is a federal report that's public knowledge called the 416 that is Colorado's report card to the federal government on how are we doing on EPSDT services. And it isn't necessarily glowing. And it reports things like the screening, how we're doing on screenings at different ages and stages. And, it's really good in the baby stage. It's really good in the toddler stage. It's really not okay in the middle school, elementary. Then you get to middle school and it falls completely off except for sport evaluations. So, there are things that are watched, but there are things that are very frustrating because it isn't as clear for us how to get it. No, it should not be on the parents to educate the provider. It's one of the reasons why we work with Colorado Access and are trying to work with the providers through Colorado Access, because we need them to better understand EPSDT and to put it on forms, honestly. And you guys are frustrated, and like I've been doing this a long time. And it should be a known thing, but we're lucky. In Florida, they only use EPSDT when a child is moving from one foster care to another to do a healthy screen. That's the only time they use EPSDT. And in a presentation that I was doing on Medicaid waivers for that state, they told me not to mention EPSDT at all because it's not used. So, I mean, we're lucky that we have it and that it's actually active in the state of Colorado.
Yeah, I think in theory, if EPSDT was working perfectly, no members would need to know about it. We wouldn't need to know that it existed because it would just happen behind the scenes. But
Right.
because it doesn't always work the way it's supposed to, and providers don't always understand, and then it really ends up becoming part of our spiel. The one that gets me all the time is we hear like supply companies will tell you things like even our own, they said, we will only cover feeding pump bags or syringes. You can't have both. Medicaid won't pay for both. And I was like, let's play this game. Yes, they will.
Yeah.
Like,
that's EPSDT. That's a
Yep.
really good example of EPSDT.
Yeah. And they still haven't billed it to Medicaid because I don't think it's worth it to them. So they just started as providing us syringes for free. And I was a little like,
Yeah.
this is a dumb policy for your company, but as long as we get the things we need, you choose to bill however your heart desires. But
Well, I get frustrated on the fact that like they've now made all medical beds a form that you have to fill out for all medical beds. Doesn't matter if you're looking for a hospital bed or a cubby bed or whatever, you have to fill this form out, but nobody knows about the form. It's on the website. It's on Medicaid's website, but nobody knows to use the form or that it's supposed to be completed. And it's like, how can we not know this? Right? I don't know.
yeah.
I could go on all night, guys. Yes, Corinne, this is part of the problem, is the fact that other families don't know to push back. It's one of the reasons Family Voices exists, is because we do help families understand that they have a voice and that they do need to push back. And it's not okay how it's all done. It really isn't.
Yeah.
So.
Well, and I think the thing that comes up too is that like not knowing that it's an extra benefit of like, we went 4 months of my daughter's life before we even got on a waiver, which got us Medicaid, which got us to EPSDT. And it's like, we could have had that from the day she was born. So what were we paying for in those 4 months, or how many therapy visits were we not allowed, and things like that, where like all of that kind of goes hand in hand of, like if you don't have a waiver to get you on Medicaid right away, then you don't know that like there's this other benefit that you can get, to really trying to like help people understand that too, that there's so many services with their waiver, but then like if you're getting Medicaid, you're getting also this, which is great. So helping people understand that.
Yeah.
Yeah. So that when you have private insurance, some cover a lot of things. And so EPSDT is part of what makes Medicaid so valuable and so much better than most private insurance policies, especially for kids.
Yeah, it's the no copays. That's all EPSDT. So I'm glad you all were here tonight. I'm on this snowy night, and knowing you've got kids at home tomorrow and all the things, I really appreciate your time. I will stay on the time in case there's more, but happy to answer any other questions. If you have a specific to your kid, we can schedule another time, or you know how to get a hold of us. But I appreciate your time. And Selena, I'm really glad that you learned tonight that it's crazy that you've been in this space for 6 years and didn't know. And that's part of why we do what we're doing. and we feel pretty passionate about it. So anything we can do to help you, we will do.
Thanks, Christy. Always so informative and so helpful.
If there's
Great.
anything you all need, let me know. Lisa,
Awesome.
did you have a question?
I have a unique case. I'm a grandmother, and so I don't get anything covered by Medicaid, although I'm a secondary caregiver to my grandson. So I have him, at least 1, 2 nights a week, sometimes 3 or 5 times a week, vacations or therapies or things like that. Do you think that there's any opportunity to use EPSDT?
Well,
as far as,
so
a
are you
medical
the parent? Are you the caregiver or only partially?
secondary. No, I'm grandmother.
Secondary, okay,
Mom is the
'cause
primary. Yeah. But like
if-
I'm like a divorced parent here. I'm like dad.
Okay, all right. Because if you were the caregiver as a grandparent, you automatically get Medicaid.
Right.
Does the kiddo
Yeah.
have Medicaid?
Yes.
Yeah, in terms of like getting duplicates of things, is that what you're
Yes.
thinking, Lisa?
Yeah, like a
the
medical
heat pump
bed
for
or
your house and their house, or
Yes.
a medical bed for both
Yes.
places.
Yes. Isn't that part of EPSDT?
If it's
That's what it
medically
sounds like
necessary.
to me. Yeah.
Yeah. So is it, I mean, how am I trying to say this? I'm trying to say it nicely, Lisa. Apologies. Is this kid medically fragile? Like, are there medical services that you need, like a pump for your
Yes.
house? You're
Yeah.
not
And so
moving
I
it
have
back and forth.
right. Yes. Now I've got stuff. I've gotten stuff on, our special needs Facebook page and things like that. So yeah, definitely he's in a chair. He's now 90, 95 pounds. So I'm trying to modify my bed to get him in there. I have a Hoyer lift that I bought used. I mean, I just try to have everything. So to minimize the transfer of things, but I'm really thinking a medical bed that goes up and down. I'm much shorter than his mom. It doesn't matter. I care for him at my home.
Okay. I love this question. And I want to phone a friend. No, I really do. I want to text Gina and say,
Okay.
can we get a secondary, give me an example of something. Is there a feeding pump? What are you carrying back and forth?
It's literally, for me, the biggest safety concern for me is a bed that goes up and down that I can
Okay.
transfer him to safely.
Okay. All right.
And that's not
And-
something you even could transfer between two houses. So
Right.
I
me.
have seen just in adult land, which E EPSDT would hopefully make this even easier, but in adult land, I've seen when a kid has to go back and forth between host homes, they have had to fight, but they have gotten special beds covered at both homes.
Yeah. So I think what we need to do is ask, honestly.
Okay.
So if you want to put a contact information, if you don't mind, in the chat,
Sure.
or I can put mine and you can just email me. Why don't we do that? I'll do
Okay.
that.
Okay.
And then I will ask Gina, if she's in tomorrow, I will ask her. If not, it's going to be Tuesday because Monday is a holiday.
Okay.
Veterans Day, just FYI. So
Thank you.
but I will look into that and see what I can come up with. Examples in your email, examples of what you'd like in your place. So the bed that goes up and down, is there a special bath chair that would be helpful? Shower chair?
Honestly, I am the first one to ask. I'll take it. I'm a grandma. I get nothing paid by Medicaid. So I definitely have a bath chair. I have most everything. It's really the bed. And for
Okay.
me,
All
it's
right.
that bed that goes up and down. But I'll give you
Yeah.
other examples, all the things I have. But I really
Yeah.
do try to get them second hand-me-downs, anyone that's giving them away. For sure.
Right.
I exhaust every opportunity.
Okay. All right. Well, let's send me an email and I will find out.
Thank you so much.
Okie doke. I can give you 10 minutes back in your snowy night.
woohoo. Sounds
Okay.
good.
Thank you all very much for listening and being here. I appreciate you all.
Same. Thanks, Christy. Everybody have a good night.
Bye.